Good evening, everyone, and welcome to Understanding Clinical Trials, brought to you by the Cancer Wellness Center and Susan G. Komen. My name is Savina Chacheva, and I'm the Program Director at the Cancer Wellness Center, and I will be moderating this evening's lecture. With us this evening, we have Fabiola De Chico, Program Manager at Susan G. Komen, who will share more about her organization and the incredible work they do. We also have highly acclaimed Komen scholar, Dr. Mariana Chavez McGregor, our presenter this evening, who will provide an overview of clinical trials, explore the potential benefits and drawbacks, and address common misconceptions that surround the topic. Before we get started with the lecture, we would like to take a minute to tell you about our organizations. I would like to welcome Fabiola first.
Hi, good evening, everyone. My name is Fabiola, and I want to thank Cancer Wellness Center for this invitation and the opportunity to share more about Komen's Patient Care Center, our mission, and strategic imperatives. I'll start off by speaking about our impact. As many might know, Komen has been around for quite a few years, over 40 years, and we've been at the forefront of change and mobilizing innovation. We have played a role in the development of 29 life-saving FDA-approved breast cancer drugs over the past 30 years, and they are now being used in many clinics. We have invested nearly $2.5 billion in advocacy and patient services, including education, patient navigation, screening, and diagnostic services, including financial assistance. Komen has been the voice of the breast cancer community by advocating for policies that accelerate research, ensure timely access to high-quality care, and elevate financial burdens for all populations. Together, we've been uniting communities and bonding with a common interest and coming together to deliver a greater impact in ending breast cancer. Next slide. So I want to go briefly talk about the why. Well, the why Komen is aiming to be that leading breast cancer organization. Breast cancer affects women and men, the young and the elderly, and it doesn't discriminate race or community. More than likely, you are someone that you know have been touched by breast cancer. And at Komen, we understand that breast cancer changes people's lives. It affects the individual who was diagnosed by the disease, as well as caregivers, family, and friends that see their loved ones battling the unexpected journey of breast cancer. Here are some alarming breast cancer statistics that remind us every day the why we do what we do. Every 12 minutes, one woman in the US dies from breast cancer. And breast cancer is still the most common cancer in women in the US and the most commonly diagnosed cancer among Black and Hispanic women in the US. This year, nearly 320,000 people in the US are expected to be diagnosed with breast cancer, and nearly 3,000 men. This is why Komen is dedicated to supporting the breast cancer community by accelerating research, expanding our impact on public policies through advocacy, and providing direct patient services that address economical, medical, social, and emotional impacts of breast cancer. Next slide, please. Now I want to go over our mission and our vision. Komen's vision is pretty simple. It's a world without breast cancer, and our mission is to save lives by meeting the most critical needs of our communities and investing in breakthrough research to prevent and cure breast cancer. Komen is taking a comprehensive 360-degree approach to fight breast cancer through driving research, providing care, taking action, and unifying communities. Next slide. To achieve our mission, Komen is focused on two things. The first one is to conquer aggressive and deadly breast cancers to help people live longer and better lives. This work directly affects those living with metastatic or stage 4 breast cancer and those who experience an unexpected late diagnosis or recurrence. The second is to ensure all people receive the care they need and advance health equity. Here, we are working on initiatives that help people overcome barriers that result in breast cancer disparities. Health equity means that everyone should have a fair and just opportunity to be as healthy as possible despite of their cultural and demographic background, with a focus on breaking down barriers for people who experience inequities in healthcare that lead to disparities. And finally, I want to share about our Coleman's Patient Care Center. For many, the path to high-quality breast health care is very complex and challenging, even in the best circumstances. Susan G. Komen is committed to ensuring all people receive the support and high-quality care they need at every step of their breast health journey. Coleman's Patient Care Center is a suite of integrated services that work together to ensure that no one faces the journey alone. The Patient Care Center, also known as PCC, has navigators that are culturally responsive and dedicated to care. They offer free, personalized services to patients, caregivers, and family members. Our Komen navigators can provide information and educational resources about breast cancer screening and treatment options. They can help you and your loved ones understand the breast cancer diagnosis and connect you with resources and financial support through our financial support assistance program and other external programs. They can hold your hand every step of the way through your experience. So I want to thank you for this opportunity, and I'll pass along the part to Savina. Thank you.
Thank you so much, Fabiola. It's amazing to hear all of the work that you're doing, and we really appreciate this partnership on this informative lecture this evening. For those of you who are joining us for the first time and I would like to share more about the Cancer Wellness Center. The center was founded in 1989 as a nonprofit organization with the mission to help anyone touched by cancer find a way forward. Each year, our free counseling services, support groups, and health and nutrition programs serve over 2,000 community members of all ages and backgrounds. People with cancer, family members, friends, and caregivers all come to us to connect and cope. Our services, which are both virtual and in person, include education programs like the one today that aim to help you navigate the very challenges that come with living with a cancer diagnosis. Wellness classes like yoga, meditation, nutrition, and more that provide a holistic approach to healthy living. And support services including counseling for individuals, families, couples, children, and those bereaved, as well as support groups that are designed to help our participants manage the mental and emotional impact of cancer. If you would like to learn more about the center and connect to our free programs and services, please visit cancerwellness.org, and the link will be included in the chat for you. Thank you again, and now I would like to welcome our presenter this evening. Dr. Mariana Chavez McGregor is a medical oncologist with a clinical practice dedicated to the care of patients with breast cancer. After finishing medical school at the Universidad Nacional Autónoma de México, she obtained a master's in science degree in clinical epidemiology at the Netherlands Institute of Health and Sciences. She completed her clinical residency in internal medicine at Washington University School of Medicine, followed by a clinical fellowship in medical oncology at the University of Texas MD Anderson Cancer Center. In addition to being an active and compassionate clinician, Dr. Chavez McGregor is committed to an academic career. Her research program focuses studying patterns of care, outcomes, and disparities. She has extensive experience evaluating cancer care delivery, toxicities, and complications of cancer treatment. In addition, she has been involved in the planning, design, and implementation of clinical trials and is an active member of SWOG, currently serving as the Executive Officer of International Affairs. She has received a number of awards, including the SWOG Young Investigator Award, the Multinational Associate of Supportive Care in Cancer Young Investigator Award. She has received the Achievement in Clinical Research Award from ASCO, was honored at the MD Anderson Faculty Scholar Award, and was recently named a Susan G. Komen Scholar. She has served ASCO in a number of roles and currently serves on the board of directors. Dr. Chavez McGregor is an internationally recognized breast cancer expert who has written more than 150 articles review articles, invited commentaries, and book chapters related to breast cancer. It is quite an honor to have her here this evening. Welcome, Dr. Chavez McGregor.
Well, thank you so much, Sabina, for the more than generous introduction. Welcome, everybody, to this webinar. As Sabina said, I'm a breast cancer doctor. I'm a researcher, but before of everything, I'm a physician. Taking care of patients, it's what keeps me grounded and motivated. And to that, well, I'm going to be talking about or using maybe some examples about clinical trials related to breast cancer, since that's what I do. I think the concepts that we're really going to touch on apply to the care of individuals with cancer, regardless of cancer type, regardless of gender, regardless of age, as long as we're talking about adults, since there's some unique issues with consent in minors, but in the care of adult individuals living with cancer, I think you're gonna see that all the basic concepts really apply. So I believe it's gonna take me about 10-15 minutes to go over the slides that I have prepared for you. And then after that, we can open for discussion and questions. The Zoom has a chat feature, so make sure that you enter your questions over there. We'll be happy to review them. So these are some of my disclosures, and none of that is relevant for our presentation today. And this is what I'm hoping that we can cover. Cover what are clinical trials, and very importantly, why they matter. What are the phases and the types of clinical trials, since that can be a bit confusing, to then maybe talk a little bit about what are some of the benefits and risks associated with this type of research, and then what are some considerations if any of your family member or loved one is considering to participate in a clinical trial, to then finally talk about some myths, some facts, and then have some closing remarks. So to start, what are clinical trials? Clinical trials are research studies, and they're research studies that are testing new ways of prevent, of diagnose, and or treat a disease. We're focusing right now talking about cancer clinical trials, but we have clinical trials in cardiovascular disease, diabetes, Parkinson's, Alzheimer's, you name it. These are scientifically rigorous studies that are trying to answer a specific question. And when we think about trials, a lot of these studies, what they do is that they're trying to evaluate the safety and also the effectiveness of treatments in order to improve the outcomes and the quality of life of patients. I think it's key to think that clinical trials try to answer crucial questions. And they can be different questions depending on the type of clinical trials, but there are questions about safety. Is this drug or this combination of drugs safe, and at what doses? Are they effective? And we can talk about how we measure effectiveness, because depending what's the goal of the clinical trials, we may measure different things. We could measure how tumors shrink. We could measure how long it takes for cancer to grow. We could measure whether cancer comes back or not. We could measure how long patients live. But they measure effectiveness in one way or the other. And they often compare a treatment or an intervention against the standard of care. The only way that we can tell that the new treatment it's better than the current one, it's compare one to the other. Sometimes we compare the new treatment versus the old treatment with the new treatment, and we combine two drugs versus one, but it's about a comparison many, many times. And I think it's fundamental to say that clinical trials follow strict regulatory and ethical protocols. And well, there's a lot of history in terms of how research and clinical trials have been developed. Today, there's a lot of oversight by institutions to really make sure that things are done in an appropriate way. So we have institutions, we have regulatory agencies, we have researchers, but we all have to follow very strict regulatory and ethical considerations. So why clinical trials matter? I think the reality, just to say in blunt terms, is that our care today and all the advances that we've had are the results of clinical trials, all of them. The treatments that we use today came from clinical trials. And the reality is that we need to acknowledge that while the treatments that we use today to treat most patients with cancer, the results come from clinical trials, only a portion of patients with cancers are eligible to enroll. So it's estimated that about 3 to 6% of eligible cancer patients enroll in clinical trials, which brings some issues of generalizability, right? If we only select a very specific group of patients to enroll in clinical trials, are then these results things that we can apply to the rest of the population? So there's a lot of efforts to increase generalizability and to have diverse populations enroll in our clinical trials. Diverse in terms of age, in terms of racial and ethnic background. Sometimes it's diverse based on geographic location, national or international. We have a lot of global clinical trials. So we want to have that generalizability. A simple example, it is there are, for example, a number of very large clinical trials in breast cancer that have been conducted in Asian countries. And there's been concerns because we know that there are certain drugs that can have a different metabolism in different populations. So one could ask or wonder whether, results of studies on certain drugs that have specific metabolism in Asian population are going to be the same in non-Asian populations. So that's why we talk about generalizability and we talk about diversity in clinical trials, because trials, we believe, must reflect the diversity of the patient population to ensure that treatments work for everyone. There are underrepresented groups, and those are often less likely to participate. And this has been, well studied. Older patients are less likely to enroll. Racial and ethnic minorities are less likely to enroll. Patients that are more likely to experience financial toxicity or that live in rural areas that don't have access to clinical trials are less likely to accrue. So this just brings the topic of the need for broader outreach and patient advocacy to bring more trials to more patients. Now, in terms of why clinical trials matter, I think also it's very important to mention that clinical trials cover a wide range of questions, right? So for example, very early therapies that we use in breast cancer, tamoxifen, a drug that we've been using for 40, 50 years, it was evaluated in clinical trials. And it's one of the drugs that probably has impacted the lives of most, patients with breast cancer. But also we can ask questions regarding local therapy. So in breast cancer, there were a lot of trials that compare a very radical surgery, a mastectomy with the entire breast of a woman it's removed, compared to just a smaller resection where only the tumor gets resected. We call that lumpectomy or breast conserving surgery in combination with radiation therapy. And those clinical trials showed that we don't need to do a full mastectomy in many of our patients because the oncological outcomes are the same. So we can ask questions about the type of surgery, about the duration of radiation therapy. Our radiation therapy protocols have also changed because we've compared 6 weeks to 4 weeks of radiation therapy. We've compared different types of fractions with radiation therapy. And of course, we have evaluated in clinical trials very novel drugs. In the case of patients with breast cancer, we have used targeted therapies. There's one that revolutionized the treatment of patients with breast cancer that we call trastuzumab, that became FDA approved in the 1990s, and that has changed the way that patients are treated. So all these newer drugs, targeted therapies, immunotherapy, antibody drug conjugates, they were developed with clinical trials and they got FDA approval based on clinical trials. Those clinical trials, sometimes we call them registration clinical trials because they are intended to generate a new label for the drug or an approval by the FDA. In addition, not only new chemotherapeutics can be evaluated or are evaluated as part of clinical trials, but also medications that are crucial in terms of supportive care, in terms of the other things that are important for the patients, new antiemetics or anti-nausea drugs. We have today better drugs for nausea. There are drugs today that we give that they were very, very, very challenging to give 30 years ago because they were causing a lot of nausea. Now, the nausea of these drugs is the same. What we have, it's better medications to deal with that. Pain control medications, better antibiotics. I mean, you name it, right? And in addition, now we also have the possibility of the clinical trials evaluating other types of intervention. Savina was mentioning some of the strategies that the organization supports in terms of healthy living, yoga, et cetera, et cetera. We know from clinical trials that there are physical activity, acupuncture, yoga, et cetera, that can have positive impact. So we have science behind it. We have clinical trials that back up those interventions. So these are numbers that reflect the what was expected or what we anticipated in terms of new cases of breast cancer in 2024 in the United States. So more than 300,000, mostly women, were diagnosed in the United States based on the American Cancer Society. Every single one of the treatments that these patients received was impacted, influenced, or determined by a clinical trial. They are not the participants of clinical trial, but the treatments that we will offer them is a result of that. And these are curves on the trends of survival. So these are estimates of death rates starting in the 70s. And what you can see overall is that today, and we can talk about the distribution, the colors, and the differences that we're seeing, the magnitude, the benefit according to race and ethnicity. It's not the topic of this conversation. But the reality is that patients are dying less of breast cancer than what they were dying before. And of course, it's a combination of things. One of them is we're diagnosing patients at an earlier stage. And of course, we do that because we have better imaging, better technology, et cetera, et cetera. But also we have better treatments. And that it's translating into less patients having cancer come back. And even those that live with advanced breast cancer or metastatic breast cancer or stage 4 breast cancer, all these are synonymous, we can help them live longer with the treatments that we have today. This list here, it's a list of the drugs that are approved by the FDA for the treatment of patients with metastatic breast cancer. 18 in the last 10 years. So we're getting, on average, 2 FDA new approvals every year for our patients. This has changed the number of options that we have for our patients. And the results, the reason that we have these drugs, it's because of clinical trials. So we touched a little bit of this before in terms of the types of clinical trials. So a lot of us think about clinical trials as treatment clinical trials, right? New drugs, new drug combinations. I talk about surgery, radiation therapy, et cetera, et cetera. These are very important. But there are other types of trials too. Prevention clinical trials, high-risk patients, patients that have a high risk of developing a cancer. They can be a prevention, right? Like if we have you take a medication, you may be less likely, or conduct a healthier lifestyle, would you be less likely of develop a cancer. We have clinical trials about screening. We all know the importance of mammographic screening. Well, there are clinical trials now evaluating newer screening techniques, different imaging methods. We have clinical trials about quality of life. about interventions to improve comfort, to improve mental health, to decrease anxiety. We have clinical trials to remind patients to take their medications, where half the patients get a text that says, hey, take your medication. Have you taken it or not? We have now clinical trials where we have a better interface with technology, where, patients may log in their symptoms on standard treatment, and then that goes into medical records and allows the team to maybe decide to intervene to change therapies, and all within a clinical trial. And of course, we have observational studies where we don't do anything different to our patients, but we just observe what happened. So clinical trials go beyond the treatment, which is what we tend to think about. Now, how clinical trials work? As I said, there are a lot of regulatory safeguards. There are some committees that we call IRBs, or institutional review boards, or very formal committees where the study, the research, the clinical trial, it's reviewed. We call those study protocols, where everything is outlined into extraordinary detail, and they are reviewed to protect participants and ensure that studies are scientifically sound and ethically conducted. And not only that, but once the studies are approved, with all the layers of approval, there are data safety monitoring committees of individuals that are independent from the investigators, that every so often will review, that will either be blinded or unblinded, and they will have very clear guidelines of, we're going to stop the study because it's clearly better to use the combination, or it's dangerous to use it, we cannot put patients at risk. For example, we had a clinical trial, MD Anderson, not that long ago, for patients with breast cancer, and something that we call cell therapy, CAR T cell, which is used in other cancer types. Very scientifically rigorous study, very excited, supported by grants from the NCI. And after the first handful of patients got enrolled, we saw a lot of toxicities. And while the science was very exciting, the safety of our patients was first, and the study got closed. So in addition of the institutions, there are like different regulatory groups that oversee or have some type of influence in the design of the study. There are some studies that we call investigator-initiated trials, IIT, investigator-initiated trials, where somebody like me can say, I have this great idea, and I think that if we use this drug in combination with this other drug, things can do better. Those trials, we need to get funded. We need sometimes to get the pharmaceutical companies to give us the drug. There are some big pharma studies, pharma-sponsored, those large phase 3 clinical trials, comparing an old drug with a new drug, many, many times are sponsored by pharmaceutical companies. These are incredibly expensive studies. And then we have federally sponsored trials. The National Cancer Institute, or NCI, provides funding for what we call the cooperative groups. Some of you may have heard about SWOG, Alliance, Energy. These are big groups that have small sites all over the country. And then these cooperative groups submit proposals to the NCI. The NCI has a very rigorous process to decide what to fund, what not to fund. It goes through what we call the steering committee. Each cancer type has a steering committee. Things go through a process of selection. Immense majority of the studies don't get funded, but some of them get funded, and they're crucial studies because they're studies that ask very important questions that maybe no pharmaceutical company is going to want to ask. So, for example, there's been studies that ask the question of whether patients will benefit for chemotherapy or not. And the randomization is that half the patients get chemo, half the patients don't. Everybody gets an endocrine therapy. So these are very important studies that are supported by federal funds. Now, another way of thinking about clinical trials, it's based on the phase of the trial. And you can hear phase 1 trial, phase 2 trial, phase 3 trial. So what is all of this? This refers to the development of the study. And mostly we're talking here about therapeutic clinical trials. Phase 0, sometimes we consider that very early or preclinical. It explores microdoses, pharmacokinetics. Sometimes they're done in healthy volunteers. What we really will focus on are phase 1, 2, and 3. So phase 1s are studies that either evaluate new drugs or new combinations. So many of these are first in human. One of the goals is to find a safe dose and identify the side effects. And actually, the phase 1 studies recommend the dose that should be studied in subsequent phases. So one of the goals of a phase 1 study is to obtain a recommended dose for subsequent studies. But of course, they also evaluate or measure toxicity. Sometimes these studies have some very, very broad eligibility criteria. We have phase 1 studies that will be open to patients regardless of cancer type, and they tend to be small. They can be as small as 20, 30 patients. Some of them are much larger, but they tend to be relatively small. And we're trying to get smarter at not only maybe like looking for the activity of a drug in the right cancer, but maybe think about something that the cancers had in common. If we're looking at a anti-HER2 drug, we're going to look for tumors that have a lot of HER2. So we are increasing the chances of that drug to have activity. But the goal is to think about dose, think about side effects, and very early, right? We call this early phase clinical trials, phase 1, first in human, first time combinations, etc. Then we have phase 2s. These studies are larger. We think more carefully or we're more specific about the clinical trials, about the patient population, and they try to assess effectiveness. We also always look at safety, right? We want a drug that works and that it's safe to give, or an intervention or drugs that work and they're safe to give. So they assess effectiveness and further evaluate safety, and they can be one arm or two arm. It can be a phase 2 study and everybody gets the same treatment. And then we just know that it's better than the normal because we compare that with other data that we have or historical controls. Sometimes they are 2 different groups and we follow them, or 3, right? But they tend to be smaller. And then we have the phase 3 studies that are what we consider practice changing studies. These are very large studies. Depending on the setting and the cancer type, some of those studies can have thousands of patients. In patients with breast cancer in the early stages, it's not uncommon to see studies in the early stage setting of 3, 4, 5,000 patients. In patients with metastatic disease, we tend to see smaller studies, 300, 500 patients. And these studies are what we call randomized, meaning like patients, some of them get one treatment, some others get the other one. You don't get to decide, we don't get to decide. It's a automatic system. In the phase 3 clinical trials, which is what tends to cause a lot of confusion, we may have 3 arms, but most of them may have 2. Sometimes there are, we call placebo controlled. That doesn't mean that we're giving our patient something like nothing, right? It means if I'm comparing one drug to 2 drugs, right? Everybody gets the standard and then have the patients get the new drug, but to not create bias, we give to the other patients a pill that looks the same. But everybody gets the standard. Just some patients get something in addition of. But patients don't know, and we don't know. Sometimes the side effects are so typical that we suspect, but the reality is that the studies are meant for us not to be influenced by what I think that I'm taking or not, right? Everybody is randomized. They assign a treatment. and it could be, placebo because that person doesn't know if they're taking the additional drug or not. And then we have phase 4 studies where thousands and thousands of patients are treated with the standard treatments, and we just monitor for safety, effectiveness, long-term side effects, right? One thing is in a study, we see what happens when a patient's treated for 1 or 2 years compared to maybe seeing what happens to those patients decades later. So, in terms of what are some of the benefits and risks of clinical trials, I think one of the greatest benefits is that they provide access to new and promising therapies. There are sometimes patients that we don't have more options for. There are sometimes very exciting drugs that we want our patients to have access to that are not approved, that we couldn't give them as part of standard care. I think one of the benefits is that there's a lot of monitoring and extra care. Usually, in addition of the medical team, there's the research team. So patients have, in addition, a study coordinator that can help with scheduling, with, just reaching out. So everybody's really looking at things very, very carefully. Everybody receives the standard care, right? Everybody. Like, we do not treat patients with nothing. Like, everybody receives treatment, but some patients could receive something else. I think it's true that there's also potentially for some individuals, this can be very important, an altruistic component about it, where we, can help advance science and help future patients. And it's a benefit that some of the costs can be covered by the sponsor, meaning the cost of clinical trials here in the United States, it's covered by patients' insurance, but the new drugs or anything that it's extra from the study, it's paid by the sponsor. So if I'm conducting a clinical trial that requires a extra biopsy that it's not part of standard care, the study should cover for that. The study should cover for the new drug. So it provides that. Now, what are some of the downsides? Because they do have downsides too. I think there are unknowns, and there are unknowns in terms of side effects or lack of benefit. But also, we don't have certainties in general with standard treatment for everybody. But there are unknowns. The randomization, you don't get to choose, right? So patients may be not, happy when they, know that they're not randomized to the new exciting additional drug. There's sometimes with the studies that I told you where double blinded are not double blinded. If we're comparing like an injection with a pill, like people know who gets the injection, who gets the pill, right? So that can be a downside. Sometimes there could be extra visits, and the visits are more regulated in the sense that if I have a patient clinical trial, the clinical trial tells me I have to see that patient every 3 weeks. There's less flexibility compared to if I'm seeing a patient's doing great, it's Thanksgiving, I may say, yeah, okay, come on, like I'll give you extra week, we'll push it back. So it's a little bit more complicated when patients are in clinical trials. Things are very structured, right? I told you that there are a lot of regulations, a lot of rules, a lot of, like procedures and processes. So it's harder to be more flexible. This, potentially, if there are more visits, could mean that you have to be at the hospital or the clinic more often, more parking, more, et cetera, et cetera. And that can be, time consuming. Also, I guess one of the things to consider is that clinical trials, participants in clinical trials have to receive the care at the site where the clinical trial is conducted. So I practice in Houston, Texas. If I have a clinical trial patients want to be part of, I have a patient actually that flies from South Dakota every 3 weeks to get a treatment that we only have a clinical trial, which comes at a big cost, and will sometimes sponsors provide funds for travel. Most of the times the reality is that they don't. So this patient's having to engage in a lot of out-of-pocket expenses to come to receive this treatment, but this treatment has been extraordinary for, in this case, she has a breast cancer with brain metastases, and like all the like lesions in the brain had disappear, but it comes at that, additional, challenge for her family. So, when thinking about joining a clinical trial, what are some of the things that maybe it's worth considering? I think it's always important to do this in sync with your physician. The physician might be the one bringing up the clinical trial. You could be the one wanting the clinical trial, but it's a conversation that should be very natural. When I talk about my patients in terms of treatments, I would say, well, we have two options. We have clinical trial and we have standard care. Clinical trial, this is what we have available right now, but there's other clinical trials in other places, or per standard of care, this is what I can offer. So it's always important to talk to your team, discuss the goals, discuss the trial options. And of course, I think it's very important to think about the timing, right? So yesterday, on Monday, yesterday, I was seeing one of my patients. I was in clinic yesterday, and she is doing really great on treatment for metastatic breast cancer, the first treatment that we give her, right? It's been like 6 months on it, and she feels great. The scans look great. So she asked me if there were any new treatments for breast cancer and or any new clinical trials. I was like, yeah, we have a lot. And then I said, like, why are you asking? And she says, like, well, I want to know if there's anything better for me right now. And the reality is that the timing is key, because even if I have a great new exciting drug, I will not enroll her in a clinical trial. Why? Because the current treatment is working and we don't know if the next one is going to work. And clinical trials have a lot of rules. So in the metastatic setting, most clinical trials will be for patients that have not received treatment, or for patients that receive one line of treatment and the previous treatment stopped working. So we need to think about the timing. And sometimes we need to be ready to act because there is a treatment that stopped working. And in terms of making the next therapeutic decision, we have to bring, a possibility of clinical trial or clinical trials, because sometimes we have more than one option. I think it's very important to search and explore. There are big centers that have a lot of trials, but also there are, smaller sites that have funded, federally funded studies. So it's important to see what's around. Clinical trials change all the time. So what it's available today at MD Anderson, it's not what's going to be available today. In a month or two at MD Anderson, because clinical trials change. They open, they close, they go on pause. Some of the phase ones just have like few slots. We see how patients do, and then after that, we open the next, what we call the next cohort, right, at a different dose. Clinicaltrials.gov, it's an extraordinary site to look for trials. Every single trial, it's registered there. It's a search engine, but then you have to be very careful, right? Because if you enter breast cancer clinical trial, you're gonna have, I don't know, like thousands and thousands. You have to be very specific. So metastatic breast cancer, HER2 positive with brain metastases, right? And then starts like narrowing down, because otherwise can be very overwhelming. Once a trial has been identified, eligibility is something that it's very important. So clinical trials, as I said, they have a lot of rules. So for example, there are a number of drugs where patients that have heart disease or poorly controlled diabetes are just not allowed. Period. End of story. They don't let us, we cannot do it. It's considered unsafe, right? There's some new drugs that elevate a lot the blood sugar. And if a patient has a lot of high sugars or poorly controlled diabetes, we could put that patient at risk. So it's not allowed. So we sometimes require patients that have what we call measurable disease, right? That there's areas that we can measure, so then we can say, yes, it's working or not working. If we're talking about a physical activity intervention, well, patient needs to be able to do the physical activity. So there are this eligibility criteria. Historically, we were even more restrictive before than we are now. I think we're trying to be more rational. and what we include as a, exclusion criteria. For example, for decades, men with breast cancer were excluded from clinical trials. And then what happened? Like, we don't have science to support what we do with men with breast cancer. So we will do the same with like women, but we didn't have the data, we didn't have the science. And now, unless there's a reason for it, we can include in many of the trials also men with breast cancer. So just a single example on why the eligibility is important. And then, of course, there's going to be a process of consent, informed consent. And sometimes maybe we over-inform because patients are like, oh my God, that's like horrible. I don't want to sign that, which is, of course, a prerogative, right? This is a voluntary effort. You should never feel coerced or pressure to participate in a clinical trial. And my patients, I treat the same way, with the same care and compassion, if they participate in a clinical trial or not. My care will never be different, or, oh, if you don't participate in the clinical trial, I'm not going to see you, right? Like, that should never happen. But you need to be informed about the risks, the benefits, et cetera, et cetera. And it's about creating a partnership, right? We are part of your team. You are participating in a clinical trial. We as the field also appreciate that. But it's important to understand that this is a voluntary process. Now, what are some of the myths and facts or things that I often get asked or that my patients ask me when we talk about clinical trials? A lot of people think that clinical trials are the last resort, the last option. Like, you're offering me a clinical trial because there's nothing else for me. That is not further from the truth. There are clinical trials for early diagnosis, for prevention, for giving less treatment. We call those optimizations or de-escalation studies. We treat patients with early stage in clinical trials. And then the metastatic setting, we can have trials for patients with no treatments before, with 1 line of treatment, with 2, with 3, etc. So really, clinical trials are part of what we call the cancer care continuum, from prevention, diagnosis, treatment, and also they can be trials that they can also help our patients that have no more therapeutic options with the control of their symptoms, with sleeping better. So all across. So that is a big myth. In terms of what I was saying, the timing, like, patients don't stop like treatment that it's working, unless there's intolerable toxicities. But trials rarely require like stopping effective treatment to like change it, right? So if something's working, we really don't usually change. Another huge myth, I will say, the last resort, and then this one, they're like the highest, is like whether patients think that they're guinea pigs and they will only get a placebo. There are strict oversights in terms of safety, and there are no therapeutic trials with placebo for cancer, period. They're not, right? You may get a placebo in addition of something else, but we don't like not treat cancer, right? Like, it's just something that would be unethical, and we will not do it. So even if there's a placebo component in the study, patients don't go untreated. And that, I think, it's very important. We talk a little bit about the potential costs of clinical trials. And I think the extra visits or travel sometimes can be expensive. But as I said, sometimes sponsors will cover additional travel, but they will cover the experimental cost, and then insurance will cover the routine cost. So the federal law requires that the routine care it's covered, and usually, like, the insurance companies get involved. So, for example, I was talking earlier today on my way here with one of my patients that has a cancer, rare breast cancer type, that it's growing, and we have to stop the treatment, and we're looking at clinical trials. We decided on one. And we need to ask permission to insurance. We call that insurance clearance, right? So we need to justify, so the insurance know that there's going to be this and this treatment. The experimental therapies are going to be provided by the sponsor, but it's part of this, regulatory approval process that we go through. So the 15 minutes that I was going to talk, they clearly became more. But to really close this down, I think clinical trials, without any doubt, they have transformed care and improved outcomes for patients with all cancer types. I'm talking about breast, but it applies to all cancers. I think we need to continue to conduct high quality research, scientifically rigorous, relevant questions that need to be answered in this clinical trial. And I think the reality is that empowerment can give us knowledge, right? And I think we should recognize that only small fraction of patients participate. But also, while this can be an issue with generalizability, I think it underscores how each one of the enrollees makes a difference for other patients and for generations to come. Many of us that are healthy today will likely benefit from clinical trials. My husband is a patient at the hospital where I work, and he benefited from the results of advanced research, and he in return has participated donating all the blood and extra studies because he feels that. But I think we all are going to receive directly or indirectly some benefit from research. And I think we need to continue to advocate, all of us, for diversity in clinical trials, for patients to have access, to not have to travel like hundreds of miles to get to a site with a clinical trial. Shouldn't be the case that patients that live in Houston receive better care than patients that live in rural, counties in the same state, right? So I think it's important. Talk to your doctor, explore trusted resources, and consider participating, because that can help you, can also shape the future cancer care, but I think can provide benefit for you and others. It's always voluntary. You deserve all the information to make the right decision for you. And in terms of some, potential resources for finding clinical trials, as I said, clinicaltrials.gov and the NCI clinical trials search engine, I think, are extraordinary. In addition, of course, like different organizations that provide tools for specific types of cancer. So I'm going to thank Sabina and her team for the invitation, specifically to BCRF and, of course, Susan G. Komen, that also fund a lot of my research. So thank you, and I'll be happy to answer any questions.
Thank you so much. I will ask a question that was asked in submission at registration, and then move to the one question that's right now in the chat. But how do you usually, so you talked a lot about the diversity and the importance of diversity in clinical trials, diversity meaning a lot of different things. But how do you usually approach clinical trials in communities who have a negative history of clinical trials?
So this is a very important topic, and I think it's something that has limited participation in certain group of patients. To be more specific, there's been, and rightfully so, a lot of concerns about unethical practices enrolling Black patients in clinical trials from, like long time ago. But those things create issues with trust, right? And I think what we're trying to do, it's engage with communities. We're trying to make sure that, for example, I'm from Mexico. I see a lot of Hispanic patients. I can talk to them in a way that I relate to them, that it's culturally sensitive, that it's culturally appropriate. We want to have diverse teams, diverse group of doctors, diverse groups of nurses, diverse groups of clinical research teams, that our patients and our teams see each other reflected, because that can help us all be better. So I think communication, it's very important. And I think a lot of that, it's on us, the scientific community, to help build trust and communication with communities that have been, mistreated. That's just the truth.
Yeah, thank you so much. It's a really good point. Sort of the building trust is an important continuation.
And partnering with with programs, with communities, with patient advocates, right, that can help us create that link. I think that the patient navigator programs that some centers or some organizations provide can really help with that. Like make that bridge shorter, bring us
Yeah,
together.
absolutely. Communities who already have some trust, even with some constituents. Thank you so much. The question in the chat right now is, could you talk about exclusion due to previous lines of treatment? So for instance, with people who have an advanced disease, how should the patient weigh a standard of care treatment option versus a clinical trial, knowing that each line of treatment they receive could reduce their eligibility for future trials?
Yeah, so in patients, and again, I'm going to be talking about breast cancer, but I think it applies. When we start a patient on a study, I mean on a drug, right? Metastatic disease, we use one drug and then we use it for as long as it works or as long as the patient does not have limiting toxicities. The minute that that drug doesn't work, we go to the next one. And then we go to the next one. And then we go to the next one. Clinical trials also follow that development. There are some drugs that we're studying as the first treatment, and there are some studies that we want to use after patient already received the standard care. So there is a little bit of balancing act. The way that I think about it and that I like to present to my patients, choosing the treatment, it's a combination, of course, of, I mean, it's a choice for the patient, but in my role as a physician, I see it, it needs to provide knowledge, but it needs to bring strategy, right? I need to offer patients a next step in treatment, but I need to already think about like 2, 3 steps ahead. So when I offer a clinical trial or standard care and discuss the options, I always think about strategy, right? What are we doing today that it's likely not to close doors in the future? Because if I choose, for example, a drug with immunotherapy, right, for first treatment, well, drugs that work the same way are likely not to be, drugs that will be interesting for clinical trials. But I also need to offer the patient the best treatment up front. So it's a combination of knowledge and strategy. What can we do to not close any doors in the future? Knowing that the best treatments need to be used up front. I will never hold the best optimal treatment for later, right? Like it's, if I have the best drugs, the best combinations that just got FDA approved, I'm going to offer that to the patient right now because that's the best chance that I have to make a meaningful impact. So I think it's all about asking those type of questions, asking about the risks, the side effects, about the options, and thinking about the strategy. What can we do that will not close doors in the future? So options remain like open.
Thank you. So do you recommend someone having that conversation with their own physician and asking what that strategy would be so that they can understand, the plan?
Yeah, I think, like if I'm offering a clinical trial to a patient, right? Again, just today, the example that I gave you, this patient of mine was asking me like, well, is this clinical trial gonna affect how you choose like a different treatment or the other option that you told me for standard care, right? So if I'm offering a patient new treatment versus standard care, patient may want, and depends on the trials, right? But patient may want to know if she goes to the clinical trial, if later this other option still on the table. So I think those are very important conversations that are gonna like, and the answer is gonna depend on the disease setting, on the design of the studies, on what's available, et cetera, et cetera. But I think it's very important.
Thank you so much. And you talk a lot about breast cancer because that is your expertise and specialty and what you're treating too. We have a few people that submitted questions who have rare diseases like pancreatic and glioblastoma. And so some of their questions were regarding like what trials are available, how could they find trials specifically for their rare diseases?
So there's different ways of looking for clinical trials. There are different foundations or organizations, just like Komen that focus on breast cancer, that may focus on glioblastoma, on lung cancer, and pancreatic cancer. So that can be a resource. Also, clinicaltrials.gov, it's a way to search for it. And of course, your team of doctors. Sometimes some patients may seek a second opinion at a large center to explore possibilities of clinical trials. But I think just looking online at some of these search engines can be very helpful. Sometimes there are communities, online, virtual, Facebook, et cetera, support groups where you can hear about, the experiences in clinical trials from other patients. Just remember, everybody's different. And you may hear about a clinical trial on somebody with the same cancer type, let's say glioblastoma, but a patient may have had it resected, a patient may not have had it resected. So not everybody is the same. The journey, it's very different, but that's another way of start, at least like hearing things.
So search for some foundations and groups that may already have or be funding research or have some connections to help getting patients information.
Yeah, and clinicaltrials.gov, really everything is there. Talk to your doctor.
Thank you very much. A similar question was someone who has a rare aggressive metaplastic carcinoma and just was talking about how do they find studies or stay aware of what's happening. So kind of similar process as what you're just explaining.
Yeah, and metaplastic breast cancers are very rare. Big centers tend to have more experience treating patients with metaplastic breast cancer. There are few specific metaplastic trials. You can look at clinicaltrials.gov. Patients with metaplastic breast cancer, we have specific clinical trial at MD Anderson and some other institutions in Texas. So there are some trials. It's a small, rare, aggressive breast cancer type, but I will look at clinicaltrials.gov.
Thank you very much. Last question that we have here before we log off today is for people that are maybe interested in clinical trials, but they don't want to approach kind of standard of care of treatment or maybe want to treat cancer with alternative methods. What would you speak to that and sort of the importance of, why is standard of care kind of part of the practice?
So as I alluded earlier, clinical trials have where we are because of clinical trials, because of rigorous, scientifically driven research that it's regulated, where we're asking a question and we answer. I think other alternative methods have not demonstrated that. Of course, at the individual level, patients, may choose to use an alternative healing method that it's not considered to be standard. I think communication, discussion of goals with patients, it's very important. I have patients of mine that have come and see me and they said like, no, I'm not going to take the treatment. I'm just gonna, go fly to Arizona, get naturopathic medications, and I always like make sure to tell them that I'll be here to treat them if they change their mind or they see that the cancer has grown. In terms of the addition of alternative methods to standard treatment, I think we have to be very careful. There's a lot of use of drugs like ivermectin or febendazole or others that I personally don't think there's absolutely any strong scientific rationale to use. But some patients may choose to do that regardless. My main concern is the potential interactions that some of these drugs can have. So don't hide it from your providers because you may be, at risk for, unforeseeable toxicities. A lot of these products, compounds, same as chemotherapy, get metabolized through the liver. So we need to be just very careful that first we just don't want to hurt our patients. So I think communications, it's very important. Ultimately, we all make our own choices aligned with our own values and system of beliefs. And as I said, I think the role of the medical team is to provide options, to educate, and our patients will then drive and make the best choices for them. I think there are medications, or no medications, there are other things that heal that are not necessarily medicine. So I talk to my patients about good diet, about like restorative sleep, about mental health, things like yoga, tai chi, meditation. Right? So there are other things that patients can engage with, acupuncture, right, for neuropathy, for symptom control, that may not interact at all with the treatment and can be an addition and a great help. So I think it's a lot about communication and what each one of us understands by alternative medicine, right? When my husband was getting, very strong radiation therapy for head and neck cancer, he was getting like acupuncture, like he was, and he was getting massages and he was like exercising. So there are other things that we can do, but we were not putting extra things on the treatment, on the like chemotherapy, right? So get informed, talk to your team, to make the best decisions for you.
Thank you so much. And wonderful transition into the last comment that I'd like to make is that Cancer Wellness Center offers a lot of those alternative, or in addition, complementary services that you just mentioned. So the yogas, the exercise, the nutrition. We do have an oncology dietitian on staff who's specialized in board certified in oncology and dietitian nutrition. So if you would like to learn more, get connected, please visit cancerwellness.org. We also have right now a Wellness in Action initiative where we're encouraging participants to join us and move their bodies. So we've got lots of different exercises and experiential programs to get us walking, moving, and outside. So please visit at cancerwellness.org/wellness in action, and I will include that in the chat. Again, thank you so much, Dr. Chavez McGregor. It was wonderful to have you here. Thank you for empowering us with the education around clinical trials, and I appreciate you staying a little extra.